leadership and governance, family and community engagement along that track. Improve that. And then again, we'll keep this on the agenda for the full board, given the significance of this work. Very comprehensive piece of work. Thanks. So we move now again into another important area, compliance with legislation. And Hazel, can I ask you to take us through the staffing levels up, please?
Okay. So the purpose of this report is to provide a statutory 3-year report to Welsh Government, which is a requirement within our Staffing Levels Wales Act from 2016. I will remind the board that the Nurse Staffing Act became law on the 21st of March 2016. This 3-yearly report for Welsh Government represents the second statutory 3-year report to Welsh Government, and this report has already been submitted to Board and Welsh Government in March and in May of 2024 as a caveated report due to the need to include all the quality indicators up to the end of the reporting period. The need to submit the paper to the Welsh Government within 30 days of the end of the reporting period. The aim of the report is to provide ongoing assurance to the board that we've remained compliant with the requirements of the Act over the past 3 years. And the detail of what the Act covers is in there, but just to remind us very briefly, it places an overarching responsibility on the Health Board to ensure they have robust workforce plans, recruitment strategies, structures and processes in place to ensure appropriate nurse staffing levels across the organisation. And it requires the Health Board to calculate and take reasonable steps to maintain the Nurse Staffing Act in all acute, adult acute medical surgical wards and paediatric inpatients. And finally, it requires the Health Board to use a triangulated methodology to calculate the nurse staffing level in all of those areas. To note, throughout the period, there's been changes in the parameters for the quality indicators from the 6th of April. So falls now also includes moderate harm. Previously, it was only high and severe harm. And medication errors also now includes moderate and high harm. Previously, it was only never events. It's also worth noting as well that the Health Board has modernised throughout this period with AMSR and surgical redesign, and the vacancy position has improved. So the report asks the board to receive the report as assurance that the statutory requirements have been completed and the Health Board is compliant. To note the ongoing reasonable steps taken to monitor as far as possible and maintain, and to note the updated quality indicators.
Thank you for that overview. So do we have any comments? Rena and then Maria.
Yeah, bear in mind it relates to finance really, but we've been talking about variable pay earlier on and the fact that we use agency and bank. And I'm just wondering, in terms of the rosters that we currently run and the need to comply with obviously the statutory legislation, do we have flexibility in our rosters to move people across from different wards? Obviously they need the necessary skills to do it, and I accept sometimes if they're in a specialist nursing area, that's not possible. I'm just wondering how much flexibility there is, because my understanding previously there wasn't a great deal of flexibility, and that was one of the reasons why we were going out to agency a lot. So can you confirm on that or otherwise?
Yeah, so there is flexibility. There's always professional judgment, isn't it? So any given day, if you're looking to look at your staffing over a whole period, you would look to move people appropriately. You would take into consideration, have they got the skill set required? So an example of that would be the neonatal services. If we needed nurses with those skills, you might be looking more quickly to go out to agency because you might not have those skills in your patch. But there is flexibility, absolutely.
My question was in a similar vein, is that assurance that the Act requires us to do what is reasonable, but given where we are with the financial position, what is reasonable? We need to keep an eye on how that plays and to what extent that impacts our decisions around agency use, etc.
Yeah, so in relation to the Act, it's really what the Act means in terms of reasonable. It's around reasonable steps to fulfil the roster. So, and there's a number of things that are considered reasonable both at operational and Health Board level. So at Health Board level, we're taking reasonable steps to actively recruit in a timely manner, that we've got retention strategies, that we've got well-being at work strategies, and support for nurses and which support effective staff management. At operational levels, it means that if there's a gap in the roster from what what we say it should be on. It means that we're taking reasonable steps to use temporary staff from Nurse Bank or agency appropriate to the skill mix set out in the planned roster, or we're deploying staff from other areas, or in the worst case scenario, considering closure of beds. So that's what reasonable means in relation to the Act. I think you're always making the decisions to try and make sure your staffing levels are safe at the least cost, which we touched on earlier, isn't it? All the ways that we can do that. That's, you know, you start at the lowest cost to try and fill those staffing levels, but you need to be safe. You want that level of safety that we can give assurance to the board as well.
Jackie, do come in.
Just following up on Muriel's point in terms of safety, obviously considerable amount of work was into the triangulation to formulate the actual numbers prescribed on the rules that come under the Nurse Devon Act. So when we fall below those numbers, and sometimes through no want of trying to bring those numbers up, we are in effect saying that those numbers are not as safe as we would want them to be. And, you know, we may risk assess it. And we have had some difficult periods where we had significant vacancies, and we were running, let's say, 80% capacity. And certainly our workforce will say to us that that was a scary time they felt unsafe as practitioners. Fortunately, we've had a significant recruitment increase. We don't have that deficit, you know, substantive posts. But I suppose I want assurance that we are still going to use bank and agency to make sure that we comply with those prescribed numbers for the wards that come into the legislation.
So you're right, it's a really complicated approach to get that triangulation, and it is an all Wales level, so it's a fairly tested level. I think there is always that element of professional judgment, and we know that things can change on an hour-to-hour, day-to-day basis, sometimes in our wards. But yeah, I can give assurance that what we want is a substantive workforce first and foremost. We want to reduce our variable pay. We want to reduce our reliance on bank, and particularly agency. But we always will need a level of flexibility in the system to make sure that we're meeting the statutory requirements.
Jackie raised quite a concerning point, really, to say that there have been times when staff have felt unsafe as practitioners. So really we would need to follow that through, even though it's in the past, in the sense of what was the escalation? Where was it used? How would it be used now if staff ever did feel unsafe? And given that we've done this extensive recruitment and recruited up to establishment, we've heard earlier, even over establishment in some parts, so the use of bank and agency should reduce accordingly. And we've discussed this before. So Rena, can we remit this to workforce to have a really good look the whole thing around establishment control, very good, in the context that we've been discussing, particularly that we wouldn't ever members of staff to feel unsafe. And we would want to understand that the right escalation arrangements are in to enable them to feel psychologically safe when they send their concerns. Not fair. Yes. Okay, so could we remit that to workforce, please? Thank you. Did we have any other points for Hazel?
I might just,
Steve?
so the Act specific to certain areas about practice only have been close to the centre of decision making. Are you aware of any move to extend it beyond its current remit, especially I'm thinking mental health, but other areas as well?
So they were looking at that. There's been a bit of a review from Welsh Government, and I think we're waiting to hear what the next steps will be, but there'll be a kind of revised programme. I'm not sure what that will look like just yet.
Okay, thank you.
We're in a position to take assurance from the update that Hazel has given us. And of course, in doing that, we are agreeing that this report is ready to go into Welsh Government and therefore will be subject to Welsh Government level scrutiny and oversight as well. So we've taken particular note of the points that Jackie made around safe staffing levels, the escalation arrangements, the whole approach to the use of variable pay arrangements when we are at or above establishment levels. And I know we've had that agenda before. So we'll remit that to workforce to come back to us. And we have to just think about how long you think the committee might need when we take that one. Thank you. So Hazel, we come back to you then for the report on governance
Yeah,
matters.
so this is part of the routine report. It covers matters considered in committee, the ones on surplus, business cycle, common seal. It does set out that we're going to be developing a protocol around growth and led group, and we'll hopefully bring that back to the November board. We'll also be looking at governance arrangements as well with our partners and starting with the RPB and we'll bring that back. In terms of approval then, the health board is a member of the drug commissioning committee, and there's a number of documents all health boards have been asked to consider and approve, and they relate to the memorandum of agreement, hosting agreement, and also they propose subcommittee structure as well for consideration and agreement by the board today, Chair.
Any matters for this? Okay, so we're happy to we receive matters considered by the JCC. We note the protocols around Gold Command, and we are considering and approving the JCC's governance framework and quite a few other bits and pieces we want us to do here. And then we're also noting the terms of reference for Kim Todd Morgan.
Yeah, this is part of the
Risk Committee as part of the JCC as well. So there's an awful lot of work going on to actually, underpin the governance really of the JCC as it moves into a new phase. We don't have anyone on that board now, do we? Oh, I want to.
The JCC
Yeah.
has all chief executives.
So that's fine. Thank you. So we're happy with that? Good. And then we stay with you, Hazel, on the board advisory groups, and just say we are going to take a look at something.
Yeah.
And we're particularly going to look at the health professionals forum, Chris. We have got a meeting arranged. What we need to do that. Hazel, over to you.
Yeah, so this report just sets out when these advisory committees last met, and it's really pleasing to see that the stakeholder reference group have met and they reveal their membership and also have a plan now to introduce a chair and vice chair, so that's really positive. In terms of key issues discussed, then the Health Board Partnership Forum covered an update on maternity and neonate staff survey update, speaking up safely, the NMC report, workforce update and a finance update. Health Professionals Forum received a presentation and the understanding of a development of a values-based healthcare strategy as well. And then from the stakeholder reference group, they spent some time in working through a reset of that group. And they also considered the new car parking proposal from Morriston and requested some further information and updates on that. And they also received a report setting out the business that the health board had considered and agreed as well.
Thank you. Roger, was there anything you wanted to say on stakeholder?
Yeah, there was a further meeting last week as well, so since the voting was out, and it was a very positive meeting. So the stakeholder reference group was considering how best to approach the appointment of a chair and vice chair, and agreed that it would do it in a very inclusive and open way by reaching out to its networks, including the voluntary groups. So I think that's really helpful and really positive, and hopefully now we can get things back on track and really been a helpful sort of reference point for the organisation in terms of lots of things that are going on.
Brilliant.
But just for further assurance, I sat in the Regional Health and Social Care and Wellbeing event that took place with the third sector, and they really welcomed the introduction of the chair and the vice chair to stakeholder reference group.
That's good to hear. Thank you. So hopefully for the November meeting then we should have good news on chair and vice chair, and also we will have looked at the remodelling in terms of reference for health professionals forum. And Chris, I know that you will take that into the national arena as well with your colleagues. Thank you. Excellent. We'll stay with you on Welsh language. Yeah, another really important fact of Welsh language.
So this is for our report for consideration and approval by the board today. Members of the Workforce and OD Committee have provided comments on it, and also members of the Management Board as well as part of its development and framing it, as well as members of the Welsh language group as well. I just want to place on record my thanks to the Welsh language team. They're a small team, but a very valued team within the organisation and do a piece of work. The report there sets out that we've had no complaints during the reporting period relating to the use of Welsh language. There have been some compliance issues and action plans have been developed and are taken forward. It's really pleasing to see that a number of our staff do want to learn Welsh, and there's extra sessions being put on as well, which Welsh language is supporting. I think that's all I wanted to say, Chair, and happy to take questions.
Thank you very much. Nuria.
Have we had any
Then we
have we had any feedback in terms of our reporting on the standards from the Welsh Language Commissioner in relation to our compliance?
We've previously taken a report to the Work Was No Deal committee. And I would suggest that we would take a compliance report there, because I think we take a 6-monthly compliance report there. I think it's fair to say that some of the standards are a challenge for us to comply with. But the Welsh language team work with the service groups really well in terms of developing the best plans around that. Some of the difficulties related to translating job descriptions timely as well, so they've changed the process. And so the Welsh language team are alerted much quicker now in terms of getting bilingual job descriptions and adverts out as well. But it is still a challenge. I think I would suggest we probably take a report back to the Workforce No Deal Committee.
So you'll be taking the action plan in terms of how we'll be compliant to the Workforce No Deal Committee.
A lot of work to do. So we're happy to take that back as it's pagely for the work. Yeah, thank you very much. So on that basis then, are we happy to consider and approve the contents of the annual report, built in as well the ongoing actions that we've done? So then we move to the minutes of our previous meeting, and that was on the 25th of July. And again, as these minutes go around in draft for any correction comment, you don't go through them in detail. But is there anything that anyone wants to raise on the content of it? Happy to approve, thank you. And then, Hazel.
Yeah.
Rob?
The action log then, there's two that just these notes on it. There's one that was due in September that we'd be extending the timescale on that. I didn't know if Darren wanted to come in and give an update on that one.
Aaron?
That was the composition of the team for Recovery Sustainability, which I've shared with yourself, Chair, and shared onwards with James.
Okay, thank you. So we can receive the action on that. And then items for noting then, you say put the chair's report there, as usual in terms of what I have been doing. And you'll see that I have been out and about, meeting with staff and stakeholders. And when I go out and about, and everybody's made me really welcome, I have been saying on part of the full board that we want to say thank you to professional, dedicated staff going the extra mile every day when they're under a lot of pressure, and particularly financial pressure. And I do say on behalf of the board that we do understand the pressures that everybody is facing and how we recognise that they are working tremendously hard to care for patients across the piece with a number of people who've got very, very high acuity. And they're doing this day in, day out whilst facing pressures. And I also say that, you know, we are doing really well on aspects as well as we talked earlier around chronic care. And I say a big thank you on behalf of the board, and I'll continue to do that. And I'm sure we all do when we go out and about, because it's really important given the challenges that are facing us. So I've not been notified of any other business, but has anything occurred to anyone as the meeting has been going on that you want to discuss? Louise.
It's only just occurred to me. I just wondered whether we monitor did not attend appointments, because I'm conscious from a personal information that often patients don't turn up for all sorts of reasons. But given our waiting lists across the patch, how do we know whether these patients actually will ever turn up again? what information do we have? How do we monitor it? How do we move it forwards? Because I can see it's a big problem. And you then have staff sitting around twiddling their thumbs, texting me about the builder.
It's great for me to respond, thanks, Chair. So I think it's fair to say we haven't monitored it as closely as we should have been over previous years. It is now part of the 3Ps programme in particular, and it's one of the metrics that we're going to be measuring more formally going forward. We also have the ability to measure it, and the rules on waitlist management say if an appointment's been agreed with a patient in beforehand, then if a patient DNAs, it should be discharged back to the referring clinician. Sometimes we get into the scenario where our clinicians are reluctant to discharge patients, either due to concerns on the referral or the urgencies, etc. But I try to point out to them as much as I possibly can. You can't make a patient come. And if the GP thinks the patient's under the care of secondary care, then they're not focusing on them in the primary care way. So discharging them back is actually the safest way to manage that referral, because then the GP knows that that patient hasn't attended and will do more to make sure they do if there are clinical concerns. So trying to close the loop on all of that. What we can, obviously, some of that is around, it's not always possible to agree an appointment with the patient beforehand. So therefore, we shouldn't discharge the patient. We should do our best to make sure we contact the patient and agree an appointment for them to turn in. But you're right, we get some patients who DNA, even on cancer pathways, they DNA multiple times. We don't discharge on a cancer pathway. We do have to close the loop on making sure we contact the referring clinicians in that one. There is more for us to do to make sure that we make sure the patients and referrers are aware if a patient has been discharged from a waiting list following a DNA on any waiting list, and that's going through our standard operating procedures now as part of the work we do on waiting list management.
And do we have the IT support ability to be able to monitor it really closely?
It does rely on users using the system in the right way. But assuming it's used in the right way, then your digital colleagues can pull reports out for us. And we drill that down into specialties, subspecialty and consultants to make sure they can see what's going on in their own areas. I think it's fair to say some services previously have managed demand by overbooking clinics with a high DNA rate. That's never a good use because patients turn up, then you've got patients waiting too long. So it's trying to get a really best practice in line to manage patients in the right way.
And it does speak to a wider point, Louise, actually, on access, was that Angela and I were talking about earlier. We are getting ready to bring a report to the board on access issues. And of course, having access and not taking it up then is an element of that. So we will be coming back to that. Would be a good point. So we've got Darren, then Jennifer.
Page 68 of the performance report. 3/4 of the way down. DNA.
Sorry.
You're going to need a magnifying glass, but just to share, it runs between 8 and 10% for new appointments. It's slightly lower for follow-up appointments.
So it's quite high.
It's quite high.
Yeah. Around 5% is
Could you put money on
it should
it?
be.
I mean, how much are we talking about?
If we know they're not overbooked, some compensatory actions, as Deb said, is overbooked, and we could value that.
And interestingly for Swansea Bay, our follow-up DNA rate is lower than our new patient DNA rate, which is not what you see normally.
Jennifer.
I was just going to pick up that point about access and how we understand access, because that point about understanding why somebody isn't able to come to what is available to them is an important part in terms of how that drives inequality. So it's getting into that conversation of understanding what would work best for that individual, as opposed to assuming that somebody not turning up is deciding not to engage. And I think that's the item that we want to bring through, isn't it?
Angela, then Rena.
Just on that, I think it's really important to know that there is a variation across services in terms of the DNA rate as well. And I think it's really important that services do know about that rate so they can actually address it. So there may be something around communication, how are they communicating to their patients about follow-up appointments need to be complied with, and there may be some learning within services. So I think it's really important that they have that information available to then make changes in terms of their communication out to the patients. And to Jennifer's point, I think it, again, feeding back to what Deb was saying, that
the loop needs to be close to the GP so they can be followed up and people don't get lost and fall into cracks. So once the GP knows that the patient hasn't complied, and they can then take up that opportunity whenever they see them again to address it.
Isn't it also internal communication, so that if one department refers to another and the patient doesn't attend, either because they haven't understood the importance or the need, and that's fed back to, it's internal as well as
To the referrer,
Yeah.
whoever the
Yeah.
referrer is.
Yeah, I think it always needs to go back to the referrer so they can then take accountability and feedback to the patient and have that interaction.
Lena, you wanted to add?
Yeah, I just wanted to ask Matt, in terms of how far on are we in terms of making sure that people get their text to tell them that their appointment is, because when you look at it, you know, deliveries, we all get them. These days, they tell you get a text on the morning, it's going to be delivered between whatever. So I just feel if it can be done on that kind of, surely we should be able to get people's mobiles and get their appointment reminders. I've just had one while I've sat here for the dentist appointment I got tomorrow. So you see what I mean? I just feel it's absolutely essential that we move forward with this.
So at the moment, we've got text message reminders. We do them as a default 3 days prior to the appointment. There's more that we can do probably in nudge theories and, you know, when is the right time to follow up with another one, maybe even break that down into age categories of, you know, what's the best method to nudge our population. The other thing is virtual consultations. And what is the reason why the patients are DNA in? There may be a cohort that we can really push the virtual consultation option if it's to do with transportation or other reasons that they can't actually physically get to the building. So we've got the tools. I think there's more we can be doing with them.
So I just make one last point, Chair, if that's okay. It's on the access bit. I think that's why it's really important that we have better conversations with referrers, especially if they're primary care referrers rather than secondary care referrers, because they will have seen that patient in the first place to refer them in. So any concerns around access or, you know, issues that we need to pick up, that's the best time to pick it up rather than waiting for a patient to DNA and then worrying about it. So it's that ongoing dialogue between the referring clinicians and the accepting ones to make sure we know how to manage that patient, so we are giving equitable access.
So when can we schedule this to come back to a full board discussion then around all the different aspects of access, and would it go via population health first? Because if here was Jennifer says, you know, a key issue around access and equality. Should we take you through population health first? Steve?
We did in our last meeting,
Yeah.
I didn't bring it up in the report. It's relatively controversial, but it does regularly come to us.
Three of the items that we discussed in population health all mentioned access in one way or another, so it does fall right neatly with what we've been discussing in the meeting that I was at. I think.
Thank you. So if we remit to population health then to do this piece of work that we need, and then we'll schedule it perhaps either January or March for full board. You tell us, Steve, which one would be preferable, so that we manage this before the end of the financial year, so it helps into 25-26. Thank you. Thank you very much. So Chris, I think you have some really good news on which I heard.
I have. Our Welsh Fertility Unit, you will remember, we were escalated to level 3 in June 2023, and then further escalated to level 4 with issues around sustainability and being able to manage regulation in 2024. We were de-escalated in June back to level 3, and we have today received a letter that we are taken out of escalation monitoring to level 1. And we have completed, you know, the work that's done. We've appointed persons responsible, we've managed recruitment, and we've done a lot of work around quality and looking at the sustainability of the unit. So, yeah, so we were hoping to have it before today, but we had it this morning.
That's a lovely way to end. And congratulations for everyone who has worked so hard to achieve that. That's a really good job.
Yeah.
Do you want to send Jean?
No.
That is the right answer. Well done. So just before we close then, we've got an item around meeting effectiveness, and we are still recording, so we're in public session, so people will be able to see the board having a look at. what's worked well, what would we like to do differently, ready for the next meeting. So it won't be the only way in which we can feedback, because anything else can come into Hazel, please. But are there any initial reflections on our agenda today, please?
Go on, I normally, in terms of governance, I think it's really good practice that we are now adhering to noting, assurance and agreement, approval, sorry, I think of the word.
Yeah.
So I think that is good practice that we're starting to reflect.
I'm a pedant, Jean, as you know, but I do say, board will only note if it wants to put something in the public domain, that it doesn't intend to do anything. Because the board is a decision-making body, so it's taking decisions or it's taking assurance on decisions it's already taken. And working through if it's not progressing, question of the reason. So what we do, we only note things when we just want the public to know them. So I think we are getting it. So thank you very much for that reflection, because I think this is a work in progress, but it's really important because the board's full, and that's what I explained there is at the beginning of the board. What do you need? Thank you. Gloria.
I would definitely echo that. I think that what has been really refreshing about this session is that I didn't feel we left anything hanging. We actually had an action to follow with everything that we raised, which I thought was really, really good. I would follow on from that. I think that there is a bit of work around the papers. So there's a lot of noise in the system, and we've had this discussion before around some of the information that gets put in front of us. There's a lot of noise that isn't necessarily relevant, and it's about tackling that noise, putting it aside and getting focused on what happens in hand. So for me, there's a bit about, you know, we are a data-rich organisation. We just don't know how to make good use of data. And that analysis is essential in terms of the reporting to the board, because that gears our debate and the actions that we follow through. So that would be my only ask, is that I can see some of the data analysis we need to get smarter at. Thank you.
Jean,
Could I make a comment on that? Because I think we're looking at things from a number of perspectives here. When I came in, the amount of information that was provided was really, really useful for me. Okay, maybe not for presentation to all board members, because the level of understanding and level of knowledge of the system and what was going on was unique to each individual. So for me to start off with, that's really, really important that we have an underpinning knowledge before we start discussing items. But that could be referenced prior to the meetings, as it should be in our reports. The second point that I would bring up is Matt's agenda is growing by the day of the committee. So he's probably got that when in fact, I know he's got the help with using data, which is why it's in our new digital data, and helping individuals to use data to analyse information. We've got a brilliant exponent sat on your right who does that very, very well. So as we're all learning and moving towards that, I think Matt's going to be very, very busy in the future in terms of using data and analysing data more.
Good shout for you then, Matt. No leave planned, I hope. Okay.
I just,
Steve.
minor point, and it's probably another one for Matt, I'm afraid. I'm just thinking in terms of our communicating to the outside world, people that are watching us live and may watch us on YouTube later, that's pretty much what they see.
Yeah.
And that is not very user friendly to watch a 4-hour meeting. I just wonder whether I don't want to spend too much money, as Darren will get cross, but I wonder whether we can ever get the technology a little bit smarter, so that, I mean, there is technology that makes it much easier to watch this sort of meeting online, isn't there? So we might give it consideration sometime.
Can I just ask a question? How many people are actually watching?
No one at the minute, because it's not live, is it? No.
How many people have watched? So nobody. Right. Okay.
Don't know if the corporate team have got those figures, if you analyse that.
An average of 50 people down the video.
So that's, you know, that's
Mix.
Just quickly back to Steve's point. So we have over the last couple of years analysed what's going on in this room. Certainly made improvement to the audio that we get from the room. But yes, the technology, the video, as you see, needs some investment in it. It is on the list. But again, it's priorities, isn't it? You know, that's quite high cost compared with the number of laptops that you can buy to replace what clinicians need. So it's difficult, but we noted, yeah.
That's what we'll have to do.
Okay.
So dwi'n gael y gyfarfod nawr, diolch mawr i'n gyflwynydd, diolch yn fawr i chi gyd. So, we're closing the meeting now. Thanks very much to our presenters and thank you all for your contributions and see you next time. I will now, bye for now. We will need to continue so that we can turn it into the